Good morning, everybody. Thank you very much to Kira and the team for the opportunity to speak to you today at your refresher meeting. The first topic I'm going to talk about is deaths associated with anesthesia, really to look at what we have learned in the last 60 or 70 years about this. Now, my name, as you can see there, is Michael Irwin. I'm a professor of anesthesiology at the University of Hong Kong. I was born in Ireland, educated in Scotland, and have now lived in Hong Kong for 30 years. So we are currently going through a big fifth wave of COVID, and I'm sure it's similar to what you've all experienced. It's been a pretty traumatic experience, and this is why the lectures are being given like this with pre-recordings and so on, rather than live. So please bear with me, and I hope you can follow this okay. So why did I get interested in this? Well, really it was because of my role as editor of the journal Anesthesia. It was the 75th anniversary of the journal last year, and the editors were asked if we could pick a paper from a certain period that we would like to discuss in an editorial. So I chose one from the 1950s. We'll come to that in a few minutes. The relevance of this plaque, this is a plaque from London, UK, where the first ether operation was performed by a chap called Robert Liston. And Liston was interesting in a way that he was that kind of old school surgeon of that time whose supposed speed and showmanship were a bit of a hindrance to his operations. He was very famous because he was the first surgeon to have a triple mortality in amputating a patient's leg. He managed to remove his testicles. The patient died, cut off two of his assistant's fingers, who also died from sepsis. And apparently someone who was watching this traumatic surgery died as a result of emotional shock. So the first known surgery with a 300% mortality, hopefully the last as well. So why mention Liston? I think it's because it reflects how much things have changed within our own specialty and in surgery since these very early days. You know, even when we look at, I do a lot of spine scoliosis surgery. You know, imagine, it's difficult enough nowadays, but imagine trying to do that with a patient in a prone position, holding a face mask like this, open ether and so on. It's just unbelievable how difficult these things were, and what we really owe to the pioneers of our specialty and how things have developed in terms of techniques and in terms of safety over the years. Now, to get to the paper that I chose to look at as part of my editorial was published through the Association of Anesthetists of Great Britain and Ireland, and they were first developed in the 1940s. And in the late 1940s, the council decided to launch what they called an investigation of deaths associated with administration of anaesthetic. Now, this is something that we would kind of take for granted nowadays in modern audit, etc. But this was really a major thing at the time. This is the first attempt really to audit deaths related to anaesthesia in the world. Actually, there was one actually done by Beecher and Todd in the United States around the same time. But these two, Beecher and Todd and this one, were the first to really look and try and analyze and classify the causes of these deaths. It was known that anesthesia was dangerous, that surgery was dangerous, but we weren't really sure exactly why and what could perhaps be done to try and improve the situation. So that ended up being the most cited paper in that decade in anesthesia. It was published in 1956. And it was just a relatively simple report. It was a report of only 1,000 cases, really very small compared to modern audits. And to some extent, the auditing replies were voluntary. So they were given reply paid questionnaires that were distributed to various hospitals. and they had to rely on people's honesty and cooperation to send back accurate details that they could then analyze. And we set up a committee to look at all this and try and analyze and see what could be made from this data. Now, it's important because the 1950s was actually an era when anesthesia was really emerging as an important, especially really out of the shadow of surgery, perhaps you would say at that time. You'll see here, for example, if you look at the dates of formation of specialist societies, it suddenly accelerates between the 1950s and 1970s. This is dates from the World Federation of Societies of Anesthesiologists. You can see that the number of societies representing specific countries increased rapidly between 1950 and 1960. There were the obvious ones like the United States, the UK, European countries, but even in Hong Kong, where I work, they had developed the Society of Anesthesiologists of Hong Kong in 1954. And at that time, Hong Kong was just really a small colonial outpost of the United Kingdom. So if we look at this slide, which shows the number of approved United States residencies, you can see that there was a sort of steady progress in the early parts of the last century, but this then again suddenly accelerated, just after the Second World War, actually, rapidly within the space of about 10 or 20 years. Now, everybody thinks in their era that they have the most modern and exciting equipment. That's obviously, we think that now, but when you think back to the 1950s, this is what was considered kind of state of the art at that time. It's a Draeger Romulus machine. Draeger have actually, to be fair, been very much at the forefront of developing anesthesia technology, and I have no association with them, but they certainly have been very innovative in that regard. And so this was what was considered, really modern equipment at that time. Anesthesia mortality had actually already decreased significantly by the time these audits started being performed. At the end of the 19th century, maybe some 50 years previously, about 1 in every 900 patients would die purely as a result of the administration of anesthesia. I mean, an absolutely terrifying statistic. No wonder patients needed very heavy pre-medication before they came for surgery. By the 1950s, this has improved quite considerably, still not to obviously to where we are now, but anesthesia mortality then ranged from about 3 to 6 per 10,000. So this is certainly a marked improvement, but still, it was recognized that there was still some way to go, which is one of the reasons for these audits. You see, I've mentioned the Beecher and Todd audit in the reference here, as well as the UK audit. So in this particular audit, one of the things I had to do, which is something we all have to do in trying to classify things for auditing purposes, is to try to look at the factors which we could identify as contributing to these deaths that were associated with anesthesia. If not necessarily directly caused by anesthesia, anesthesia was certainly playing a major part in this mortality. And there are some here which would even seem relatively familiar nowadays, but others which would really be considered extremely rare nowadays. So you see there are things like regurgitation and vomiting, obstetrics, or a lot of deaths related to obstetric anesthesia. That's obviously improved markedly. Circulatory failure after administering barbiturates. Now, remember, barbiturates had only very recently come to market, and probably there was a lot of lack of familiarity about the pharmacology and use of these drugs. Unfortunately, a lot of patients were still dying because of postoperative respiratory obstruction, what they call pharyngeal relaxation. I guess that's loss of tone. Again, more drugs, chloroform, trilene, problems with apparatus, problems with intrathecal anesthesia, induced hypertension, overdose of drugs. So a lot of things related to pharmacology, and probably really a considerable lack of understanding of both pharmacokinetics and pharmacodynamics associated with these extremely powerful medications. If you think about it, the type of medications that we use in anesthesia are probably the most dangerous drugs which are available for doctors to administer. And this is the reason why there's so much time and effort nowadays, because it's training on how to use them. But at that time, about 60% of these deaths were thought to be wholly or significantly due to anesthesia, with anesthesia contributing to the other 40%. But there would be other issues as well. No, for example, poor preparation for surgery, hypovolemia, this type of thing. To come back to the issue of the 5-penton, this is maybe a bit of an apocryphal story, but you probably heard that they said that the 5-penton was the cause of more fatal casualties among servicemen at Pearl Harbor than the enemy bombs. Maybe not quite true, but it does reflect, I think, again, what I wanted to emphasize, the lack of understanding, I think, of pharmacology. This is a drug which just very, very recently come to the market. People thought it was really easy to administer, a kind of panacea, when they were used to previously just having to give drugs by the inhalational route. Anesthesia practice, of course, was very, very different. About more than 10% of the deaths were actually related to circulatory failure, this IV barbiturate I've mentioned before. I say, again, reflecting ignorance in pharmacology and perhaps management of shock. But there were also a lot of deaths associated with inhalational drugs. And one thing which maybe some of the older audience might remember, I can remember this, having carbon dioxide on the anesthetic machine, and injudicious use of carbon dioxide contributed to a certain number of deaths as well. There were also inhalational drugs which were being used, which were explosive, and there were deaths related to that, fires and explosions as well. And then many deficiencies in postoperative care. I always like to say, that when we look at anesthesia as a sort of conduit, we're only as strong as the weakest link. If we can give very good intraoperative care, but if we then neglect the patient in the postoperative care unit, then that negates all of the efforts that we make in the intraoperative care and so on. So patients dying from airway problems, hypoxia, would be very unusual in modern anesthetic care, but were not that uncommon in those days. This is just to show you that carbon dioxide used to be on anesthetic machines, and I certainly know of a few near misses which I'd heard of in relation to that. For example, carbon dioxide being left on by mistake, this type of thing. Who was actually administering the anesthesia? Well, this is the other issue. There was really not that many people who were really well trained in administering it. You can see that subsequent to these audits, in the graphs I showed you a little bit earlier, anesthesia especially was becoming better recognized, and there was training programs just sort of starting around that time. So you can see that the residency programs were increasing and so on. But at the beginning of the 50s, late 40s and 50s, when these audits were done, there were only about 10% of anesthetics were being administered by properly medically qualified anesthesia specialists. Now, interesting, in the two audits, the highest mortality was actually associated with anesthesia specialists giving anesthesia, and this is probably, I'm pretty sure this doesn't reflect their knowledge or experience, because I think these people were very knowledgeable and experienced. It probably reflects the fact that they were doing the most difficult cases and managing the most difficult patients. About 40% of cases, anesthetic residents, 20% by nurses, 20% actually done by surgeons, believe it or not, and 8% so-called others, including people like medical students, passers-by. I don't think passers-by, but who knows? It's not really very clear. Only about 13% of patients had tracheal intubation, and it was usually associated with, interestingly, with higher mortality. Only about 5% of patients were actually being ventilated during surgery, and the overall anesthesia death risk was about 1 in 2,000. This is the Beecher and Todd data from the United States. It was 1 in 370 if muscle relaxants were used. So it was actually about 7 or 8 times higher if they were using muscle relaxants, possibly because, again, ignorance of pharmacology, reversal, and the fact that many of these patients were not actually being ventilated. Muscle relaxants were given to kind of relax the muscles a little bit, but and this would obviously contribute to hypoventilation, but it wasn't being properly recognized at that time, and patients were left sort of spontaneously breathing, often inadequately spontaneously breathing. So what this has really paved the way for is this immense importance of audit in shaping our modern practice. So these early audits led on to things like the National Confidential Inquiry into Preventable Deaths. This is UK data. I know that obviously lectures in the United States, but you have similar programs going on there. And then things like the National Audit Projects, which are fantastic projects. They're now going on to NAT7, the seventh one, on different areas. For example, the last one that was published was NAT6, which looked at anesthesia, surgery, and life-threatening allergic reactions, which give us a lot of feedback and knowing, drugs that are contributing most commonly to allergy. For example, they found rocuronium, very high incidence, gelatin solutions, intravenous gelatin solutions were quite high incidence of anaphylaxis as well, and so on. But I think we all know the importance of audit. I mean, the definition is, rigorous means of measurement and improvement of the quality of healthcare against an agreed standard. So you look at what you're doing, and you look at the outcomes from that, and then you look again to see what you could do further that could improve this quality. So it's a kind of circular phenomenon, and I think it has really been extremely important in developing how we practice and improving the safety and quality of our everyday anesthetic practice. Hopefully, by determining these problems, we can actually either get rid of them or at least reduce the incidence and improve or reduce the likelihood of them actually occurring. So in those days, there was really a lack of proper formal and ongoing continual medical education training. I mean, I've been doing anesthesia now for more than 30 years, and even within my time frame of anesthesia, in the early days, we didn't have CME either. But now, this is a pretty much standard thing, and it's becoming more and more important, and it's becoming better. I think, things like simulation, for example, are coming into this, and much better independent governance through colleges and associations, societies, they can do this. Subspecialization has become much more important in our specialty, particularly things like pediatric anesthesia or cardiac anesthesia. For trainees, again, even within my working lifetime, much better supervision, better regulation of working hours, better. We're lucky in our now generation that we're getting better and better drugs. And not only that, but we're better taught how to use them, and we understand how to use them much better. Our clinical anesthetic records are improved a lot. Now moving on to things like electronic record keeping, which are very important, again, for audit purposes, also medical, legal, and education. And we have much better equipment. We've really been very lucky with that. The type of monitors, their ease of use, and their breadth of ability in monitoring. Airway devices are a very good example of this. The video laryngoscopes and so on have really revolutionized airway management. So these are all very important things, which I think we're all very familiar with. Now, although we recognize that, we also have to recognize that, if we were working in countries like where I am in Hong Kong or United States, most European countries, that we're quite lucky to have these type of monitors, but not everybody is. And things that we take for granted are not available in a lot of places, even in a lot of countries around Asia where I work sometimes. You couldn't take having a pulse oximeter for granted. Certainly not capnography can be very difficult to get sometimes. And the WFSA have been instrumental in helping organizations such as Lifebox to provide these basic levels of monitoring for countries where they're not available. And I think these sort of things are very important in terms of the global improvement in safety, not just in our wealthy countries or relatively wealthy countries. Communication was really lacking a lot, I think, in the old days between and within specialists. And this is just a picture of I took with a colleague of mine recently. This is the first surgeon I actually worked with when I came to Hong Kong, and we're still occasionally doing cases together. I think it's simple, but really vital. Communication is not just amongst staff, but communication with patients. I think in the past, it's kind of taken for granted, and patients were probably the last people to know what was going on. Now, I think particularly the United States has been very instrumental in this, because patient advocacy is very well developed in more economically developed countries like the US and United Kingdom. Pre-operative preparation was often inadequate, non-existent. Maybe the first time you ever saw your patient for surgery was whenever they were in the operating theatre. And there was a lot of pressure to manage patients who were often very poorly prepared for surgery. Now, I think there's no real excuse for that in modern healthcare. Sometimes we like to compare anesthesia with aviation, but it's not really a very fair analogy. There are things like, they say, the takeoff, the flight, and then the landing is very similar. But the whole point of an airplane is that it's actually designed to fly. It's not working properly, you don't take it off the ground. Human beings are not designed to be anesthetized. And unfortunately, they're often not working properly whenever you actually need to do things with them. And also, unfortunately, they're often not well provided with backup systems and spares. Some of them have long histories of very inadequate servicing. Hopefully, this is not the case whenever you're flying an airplane. Now, in 1977, there was a grant awarded to Association of Anaesthetists for the design and development of a confidential inquiry into perioperative death. So this ended up being the NCPOD, and this was a further development of audit and a national audit by John Lunn and Mushin. Lunn realized the importance of having surgical input to audit and not just trying to audit things by ourselves. I think what he really recognized was the multidisciplinary aspect of our perioperative care, and what I mentioned about communication and working together, things that we sort of take for granted now, but were somewhat pioneering back in the day when it's thought, the surgeons were kind of running things and so on, and you were kind of pressured to just get on with it. So they, in the 1980s, looked at the 30-day perioperative deaths in 3 parts of England. They found 410 deaths, and about of these deaths, 410, 14% were attributed in part to anesthesia. But you can see the difference over a period of 30 years. Only 3 or 0.1% where anesthesia was the only factor. So this was already a very big advance. And this resulted in what we call the NCPOD, National Confidential Inquiry into Perioperative Deaths, published in 1987, and nearly 40 years ago. And then this was very successful, and NCPOD was then established as a proper organization, produced their first report in 1989. And they continued to do so right up until about nearly 20 years ago. But then they extended the review of quality medical care also, and this then paved the way for other national and local audits, such as the National Audit Project and the NELO, which is an audit project looking at emergency laparotomy and deaths associated with emergency laparotomy. And these, as I say, have had a very major impact on clinical practice. Part of this process, and I think is a very important part, is the patient involvement and patient advocacy, which I've already alluded to. I think, it's sometimes you find patients, demands can be quite frustrating, but I think it's good to be pushed, and it's good that they are more engaged and demanding. I think it's not just helped to improve things for them, but they are very powerful in terms of pushing national societies and governments to support areas such as anesthesia and perioperative care. If they're recognized the importance of what we're actually doing. So when we learn about the past and we look at history, history helps us to shape the future. And what's likely to happen in the future, I think I've got a lecture about this actually a little bit later, so I'm not going to spend too much time on this. But I think, we're obviously going to have better medical treatments for diseases like cancer and so on. So there may be less need for surgery and anesthesia. Robotics are going to be important. We should have better techniques for monitoring what we actually do. I think it's really quite surprising that we don't really understand anesthesia all that well at the molecular level. What is consciousness? How do we measure consciousness well? Nociception, I'd love to have a reliable monitor of nociception. The ones I've tried so far have been very disappointing. We've done some research on hibernation, organ protection, and perhaps we can unlock the secrets of this, and that could lead to all sorts of things like space travel. Who knows? Personalized medicine is going to be important. Patients are getting older, but hopefully with better medical care, be less frail. What I think there's no doubt that perioperative medicine is really going to be the future of our specialty, and better integration between surgery and anesthesia. Older patients will have new concerns, particularly issues such as cognitive function, which is very much at the forefront these days. So as I mentioned earlier, I think we're only as strong as the weakest link. We need good pre, intra, and post-operative care. I think all facets are equally important. It has to be multimodal, it needs to be multidisciplinary, and it doesn't have to be expensive. So things have changed a lot in this since the 1950s when this audit was first published. Safer, better drugs, higher standards of training, CME and appraisal, much less a number of deaths associated with anesthesia, but in healthy patients. But the overall death rate, I think you could still say, is still too high, particularly in the sort of more vulnerable and frailer patients, probably because of the demographic shift. I think the concept and involvement in these systems of whole care process is and will assume much greater importance, and certainly should assume much greater importance in the future. Thank you very much indeed.